Hi, everyone, and good morning, good afternoon, depending on where you are. Welcome to the Les Turner ALS Foundation's April long anticipated learning series with Hannah Rudd, a physical therapist at Shirley Ryan Ability Lab and a former friend. Well, I shouldn't say former friend, but former colleague, current friend. Before we begin today, just want to remind you that you are not on camera, you're muted, so you can sit back, relax, enjoy the presentation. It should last about an hour. And you're going to notice to the right of your screen, there's a little dashboard with a question box. So feel free to drop any questions in the chat. Once Hannah moves through her presentation, once we get to the end, we will have time for a question and answer. Lastly, just want to remind you, in sake of time, if we go over or if something happens and you have to hop off this, the presentation is being recorded. So it should be up on our website within the next couple days or so, and also on our YouTube channel. Okay, so with that out of the way, I'm Anne-Marie Doyle. I'm the Community Education Manager here at the Les Turner ALS Foundation. Thank you again for joining us. And before we jump into the presentation, I just want to tell you a little bit about our foundation. All right. So the ALS Learning Series is made possible due to a generous grant from the Gilbert and Jacqueline Fern Foundation, along with our industry partners, Mitsubishi Tanaba Pharma America. So who are we? We are leaders in comprehensive, personalized ALS care and research. We realize that people living with ALS may feel overwhelmed and unsure of what questions or what to do next. And that's really where our support service team shines. Our team is comprised of nurses, social workers, and therapists with many years of experience guiding people and their families affected by ALS. We offer a variety of services, including visits by ALS support care coordinators, need-based grants, and connecting people with community resources. At the Lois and Solia ALS Clinic at the Les Turner ALS Center at Northwestern Medicine, we offer access to enrollment in clinical trials and a multidisciplinary team to provide comprehensive support. Again, we know that making decisions about your ALS care can be really overwhelming, but again, we're here to help. The Les Turner ALS Foundation has resources to help you learn about your options, so feel free to visit us at lesturners.org/resources, and I will be dropping that in the chat. And again, if you're looking for more information on symptoms or care options, or maybe you're interested in browsing some past ALS learning series, those all can also be found on our website at lesturners.org. Okay, so now I am so excited to introduce you to Hannah Rudd. Hannah is a physical therapist that specializes in providing patient care in the area of neuromuscular disorders at the Outpatient Neurological Clinic at the Shirley Ryan Ability Lab in Chicago, Illinois. Hannah is currently an adjunct faculty member with the Northwestern University Department of Physical Therapy and Human Movement Sciences, and has previously been on faculty at the Burdine F. Lewis College of Nursing and Health Professions at Georgia State University and Emory University School of Medicine. Welcome, Hannah. Whoops. And I'm going to make Hannah the host so you can see her screen. Oh, Hannah, I think you're still muted.
There we go. Okay.
There you go.
Does that look good? Can you guys see the
Yeah,
presentation?
that looks great.
Okay, perfect. Thanks so much for that introduction. Okay, let me pull this down here. Welcome, everyone. I'm so excited to be with you today. Just bear with me for 1 second as I get this worked out. Okay, I think we're good to go now. Let me just make sure my slides are advancing. Okay, so like Anne-Marie mentioned, I hope that this is a insightful presentation for you. I was just chatting with some people earlier this week that said, man, this is such an area that I'd like to learn more about. So I hope for people living with ALS, care partners, care teams, any providers who are on the call, I hope this gives you some general guidelines and general principles of how exercise plays a role when living with ALS, and can give you some tips and tricks and some recommendations for future work. Let's see. So like Anne-Marie mentioned, I work in our outpatient department at Shirley Ryan Ability Lab. I partner with the ALS Center at Northwestern Medicine to see referrals from that clinic in our outpatient clinic. And at the end, I can give a little bit more information about that. In today's presentation, just to go over a little expectation here, we're going to quickly just go through some of the historical perspectives of ALS and exercise. It's pretty interesting history of how we got to where we are and kind of how far we have left to go. We're going to talk a little bit about the benefits of exercise for those living with ALS. Definitely spend some time on precautions and contraindications to exercise. And then discuss how best to partner with your rehab team or how to approach an individualized program for you living with ALS. So most of us have probably heard of ALS in the history as Lou Gehrig's disease. We now know it more as amyotrophic lateral sclerosis. This first came about in the 1930s or gained popularity in the 1930s as Lou Gehrig was a prominent figure with ALS. That's where we first saw some of the interest develop in figuring out who is at risk for ALS and then how does physical activity affect people living with ALS. Historically, we have seen that research thinks that glutamate plays a big role in ALS. We know that. So I wanted to break this down a little bit because a lot of people ask me, well, why is exercise at certain levels bad? Why is it good at certain levels? Things like that. And it's a little bit unclear. We have a lot of distance to make as far as research goes, but we're slowly working towards it. So to break it down a little bit smoother, glutamate is a neurotransmitter in our body. We think of it as like a messenger molecule within our nervous system that helps our nerves send signals throughout the body. Research has confirmed that sustained increased levels of glutamate, or this messenger molecule, are toxic to our nervous systems. And this is found in most people with ALS, this increased level of glutamate. Early research hypothesized that vigorous activity with lots of high intensity increases glutamate and thus increases the risk of developing ALS in high-level athletes. So I know there's a lot of articles out there right now, a lot of people still studying this area. We haven't come to a confirmation yet, but the research is really interesting out there if you want to take a further look. So currently, we know that while glutamate does increase with physical activity, there's no conclusive evidence that identifies who's at risk for ALS due to increased physical activity. I will just put another plug in there that most of the research surrounding this has focused on high intensity and strenuous, vigorous exercise, which is definitely not what we're going to be talking about today or that what's recommended with today's research. So when we talk about exercise, we're going to be going through this in a lot more detail. We first started to see kind of this modern day research pop up in the 1970s surrounding people with ALS exercising physical activity. Some researchers believed this message, hey, we should avoid all exercise. We should rest our body, allow it to relax in order to spare muscles and preserve what muscle units are still available. The other side of the spectrum, we had researchers who said, all exercise is good exercise. We should be moving our bodies, taxing our muscles, things like that. We know that in modern day research, the answer most likely lies somewhere in between these two extremes. And that's what we'll focus on today. So why do we exercise? These are for people living with ALS. These are principles that affect everyone with ALS, without ALS, but especially the research surrounding exercising in ALS. We see kind of these three main categories. We want to focus on compensating for weakness and preventing further muscle atrophy. So we want to maintain what we have for as long as possible. All right. We want to improve functional mobility. The focus of exercise is really going to be on maximizing function and allowing someone with ALS to continue to do the things you want to do. All right. And then the psychological benefits that come along with exercise. We can improve blood flow, improve oxygen flow. We get endorphins. Movement is enjoyable. We can do the things we want to do socially and from a physical activity perspective. Going into a little bit more in depth, these next couple slides will talk about kind of the general principles about why is exercise beneficial for someone living with ALS. So we're going to really focus on, you're going to hear me repeat this over and over again today, stressing moderate intensity exercise. Research has shown that this moderate intensity exercise is well tolerated and safe among people with ALS. Don't stress, we're going to go into a ton more detail on what does this moderate intensity mean for you, and some tips on how to self-monitor that at home. We have some emerging evidence to support the benefits of this moderate intensity exercise that mostly looks at maintaining function and improving quality of life. So a lot of the research surrounds quality of life measures, not so much prolonging life, but improving quality of life. Breaking it down a little bit more. So these are our three main categories. We look at stretching, resistance training, and aerobic exercise. Stretching has been well documented. It's widely accepted. The research doesn't show any kind of adverse effects to stretching. This is something I really emphasize with the patients and clients I work with. We're going to go into depth on the goals and the benefits of stretching, but this is something that we can do on a daily basis to improve function. The next, moderate intensity resistance training. This might look like weights. This might look like active range of motion, where we're just moving our body through space without weight. It might look like using TheraBands. It might look like using resistance in a pool. This can take on a million different varieties, but it has been shown to be widely tolerated within appropriate parameters, which we're going to discuss a little bit later. Research has shown that especially moderate intensity strengthening may delay the disease progression, especially in early onset ALS. So there has been more research as of late, as of 2018, that discusses that. As far as aerobic exercise goes, less research surrounding this. It's a little bit less understood about how this affects the body in someone with ALS. But for the most part, we're seeing no adverse effects when we exercise at the appropriate parameters in that moderate to light intensity. But just to go back again and drill the point in, we need more research on all of these areas of exercise. We still have a long ways to go to truly understand the effects of all of this. So when I talk about moderate intensity, you're going to hear me reference this a lot today. This is what I mean. So we use this often in therapy. If you have been in outpatient physical therapy or inpatient, you may have seen this scale before. You may have also seen a modified version of this that goes between 6 and 20. All right, this is a Borg scale. It's a scale of perceived exertion. So how hard you feel like you're working. If you and I both go on a walk up an incline, so we're hiking up a mountain, I might rate it as a 6 out of 10. I say it's pretty hard. You might rate it as a 3 out of 10. It's not too bad for you. It's moderate. This is really based on level of fitness and where you feel like you're at. So this is subjective to you. This can't be decided by your physical therapist or by your family members. This is something that you figure out for yourself based on your fitness level. So when we say moderate intensity, we're taking this 0 to 10 scale. We're mainly going to talk between that 3 and 4 parameters. This, I usually give the example that this is doing an activity where you're starting to get a little bit breathless. It's a little bit harder to hold a conversation. That I usually tell my patients when I'm having them walk on a treadmill that you're going to start to be a little bit annoyed at me if I keep asking you questions and keep asking you to answer a question. So you're still able to get a few words out, have a little bit of a conversation, but it's getting a little bit more difficult. That's a good indication that you're hitting that moderate intensity. Now, there are other ways that we track moderate intensity via heart rate monitoring. That's certainly something that can be accomplished with an easy pulse oximeter at home, a remote tracker like an Apple Watch, a Fitbit, a Garmin, anything like that. I talked a little bit about that, but if that's something you wanted to do, I would definitely recommend partnering with a rehab professional that can talk you through the appropriate parameters for that and show you how to better track that. But this is a pretty easy, pretty widely accepted way to track intensity level. So let's dive in a little bit deeper into specific recommendations. I know that from those of you who signed up, there are a lot of questions on specific exercises. We're going to touch on some of those, but really the message is that we want to exercise. That could be whatever you enjoy doing. We're going to focus more on intensity, which is where the research lies with exercise. Doesn't really matter so much what you're doing, but how you're doing it. So going back into that stretching and range of motion that I mentioned was widely accepted. We haven't seen adverse events from stretching and range of motion. The benefits are numerous from stretching and range of motion for anyone with or without ALS. We prevent contractures, which contractures mean that a joint is stuck in a position. It's sort of like that old saying, you don't use it, you lose it. So if I never, use my arm can get stuck in this bent position and flex position. It becomes harder and harder to extend my arm, such as that. For someone who's sitting in the same position a lot of the day or standing in the same position, we often see these contractures develop faster. We want to prevent pain by stretching our joints and our muscles, things like that. This stretching, even in early ALS, can set you up for success in improving wheelchair positioning. We want to think ahead of, if I need a wheelchair in the future, I want to make sure that my range of motion is good to make it even easier for me to position myself correctly, or for my family members to help me position correctly. And then we focus a lot on improving chest mobility. Chest mobility has a lot to do with being able to take a deep breath in, which is something we'll touch on in a little bit, but we want to maintain that mobility as best that we can. So some of the areas we focus on with stretching, we kind of focus on these big muscle groups. If you've been in physical therapy, you may have done some of these before. If you're an active person, you may have done some of this before. We focus mostly on the ankles, the gastrocnemius, the soleus. Those are your calf muscles that get very tight, especially when we sit. Knees, we focus on the hamstrings and the quads, those are your thigh muscles surrounding your knee joint. Hip flexors, this is the muscles that lie in the front of your hip. These are especially prone to get tight when we sit for a long period of time. So definitely something we want to focus on. As far as the upper extremity goals, we want to do focus on all the shoulder muscles, the rotator cuff muscles, things like that. And then your hands, we want to think about what position your hands are going to be in. Sometimes we do this via splinting. Sometimes we do this with orthotics, things like that, if that's needed. All right, this is just some examples. I know that some people, when you registered, were asking for specific examples of things. While we're not going to go into specific examples because everyone is different, it's an individualized program for each person. I did want to give some quick pictures when I go through these exercises. This is an example of some caregiver assisted stretches. Up here on the left, you can see a calf stretch, a hand stretch. This woman in the middle is using a strap to help stretch her hamstring. We have some shoulder stretches, and then up here on the top right, this would be an example of stretching those hip flexors. Stretches can be done, in multiple positions. Some people, if you're having trouble laying down, having trouble breathing when you lay down, we can usually modify these to a seated position. We can modify it to a standing position, whatever needed. So let's talk a little bit about resistance training. I put this picture of a barbell, and I like it, but I want to reemphasize that resistance training means a lot of different things to different people. Resistance training, again, it may mean using weight. It may mean just using your body weight. It may mean using a band or a lightweight or, water or sand, things like that. So I think a lot of people get scared when we say resistance training, like, does this mean I have to go to a gym and start lifting weights or using weight machines? It doesn't necessarily mean you have to do that. If you enjoy that sort of thing, that's definitely something that you can do, but this can be modified to fit whatever needs someone has. So again, as far as parameters go, we're going back to that moderate resistance. That Borg scale 3 to 4, if you remember, that's starting to breathe a little heavy, but still able to hold a conversation. We're going to focus on muscles with a grade of 3 out of 5 strength. So this is a term we use in physical therapy. 3 out of 5 strength means that the muscle can move through the entire range of motion. For example, so this is my wrist, all right? Can I move it all the way into full extension, or could I only lift it part of the way through extension? We want to focus on these larger muscles that are able to still move through the full range of motion. Research shows that focusing on these weaker muscles that are less than a 3 out of 5 strength can actually be detrimental to those muscles and cause further breakdown. So you'll hear a lot of us, if you're in therapy, talk about this 3 out of 5 strength. We do a lot of strength testing to make sure we're focusing on the right ones. And then the research for resistance training, it's a little less understood than stretching, but it mostly points towards resistance training with weight, especially during early to middle stages of ALS. Once someone's in a later stage of ALS, we're mostly focusing on active range of motion without weight, more of a stretching, maybe some aerobic and respiratory training. Going back to just to reemphasize, there's no one size fits all option here. I know sometimes it's hard to not compare yourself to someone who you see lifting weights or using a weight machine, but this really can be modified to whatever your needs are. The research that's out there recommends usually 3 times per week, anywhere from 2 to 4 times a week is accepted. 3 sets of 5 reps, and then we really focus on lighter weights and more repetitions. So we are not looking to hypertrophy or bulk up our muscles, necessarily resistance training. We're trying to maintain the strength that is there. We want to focus on moderate intensity again. What can you do at that 3 to 4 level? And then we want to avoid exhaustion. This is something we're going to talk a little bit more in depth on later, but this is probably the most important message I could give, is to avoid over fatigue, avoid overworking your muscles, avoid exhaustion. The good thing is that we have these parameters in place to do just that, and to be able to safely exercise at home. So again, not giving specific examples of resistance training since everyone's different, but just throwing in a few key items that we usually focus on. We focus on larger muscle groups, things like this gentleman in the middle laying down. We're focusing on the quads and the hip flexors in your leg. We have this woman doing bicep curls. We do some rowing for some back muscles, things like that, shoulder muscles, things that are going to help you do the mobility tasks that you need to do. Again, I put this picture of a gym down there because I do work with some people who are in the early stages of their diagnosis and they enjoy working out at the gym. And I've been to a gym with a few of my clients and said, let's work on the machines. They're still lifting heavy weight, things like that. So if that's an environment you enjoy, go for it by all means. So aerobic training, or sometimes we talk about it as endurance training, it's been shown to be well tolerated with low risk of harm or adverse effects. We're still, again, the research is coming out more and more to understand it a little bit better, but overall, no adverse effects. There's no evidence that symptoms are exacerbated or that disease progression is exacerbated with aerobic exercise. And again, I'll emphasize, find something that you enjoy. The type, how you're exercising is much more important than what you're doing for exercise. So again, I have some people who are still hiking, they're biking, they're walking outside. I have one gentleman that does half marathons still. And then we can also do things like from a seated position, we can modify and make a ton of different modifications to this. As far as aerobic exercise goes, we do have to consider respiratory function and balance. This is something we really want to assess with your physical therapist, with your doctor, with your pulmonologist before we start respiratory and exercise training. Again, we're going to focus on that 3 to 4 on the Borg scale. We can also use this 40 to 70% max heart rate. As I mentioned before, this is something that we do in physical therapy. A physical therapist can help you figure out what is your appropriate heart rate. Usually 3 to 4 on the Borg scale coincides with this 40 to 70% max heart rate. And it's easily trackable with a remote tracker like a watch or a pulse ox. All right, aerobic exercise in the research is most commonly recommended for 2 to 3 times per week, more so 3 times per week in the early stages. And then usually that 20 to 30 minutes is our goal. So I usually recommend to my clients twice a week for a goal of 25 to 30 minutes. That can include rest breaks. Doesn't mean that you have to be able to exercise for 30 minutes straight, because I know that's a big ask for a lot of people and honestly not appropriate for a lot of people. Okay, so I just threw these up here because I mentioned that, said, well, what if I'm in a wheelchair? What can I do as far as aerobic exercise goes? And I just here to say there's modifications for everything. All right, we can use something like this, an arm cycle. We can do seated punching. I have some clients who do seated Tai Chi, seated aerobics classes, things like that. So we can modify it to pretty much anything to a seated level as well. All right, so I wanted to touch on this. I know there were some questions about it. Respiratory training is definitely an emerging area among people with ALS that we are seeing a lot more studies coming out in the last couple of years on both inspiratory muscle training and expiratory muscle training. We most commonly see restricted lung volume with ALS. Restricted lung volume leads to reduced vital capacity. What vital capacity means, it's the maximal amount of air that you can expel from your lungs or get out of your lungs after you maximally inhale from your lungs. Why is this important? It's important because the larger your vital capacity, the more you're able to affect the flow of oxygen to your blood and thus your muscles. So we want to maintain and improve vital capacity as much as possible. How do we do that? We do that with things like inspiration training and expiration training. We start usually with diaphragmatic breathing. You may have heard this term. We use other muscles in our chest to work on accessory breathing, which is like using your shoulders or your chest muscles. But what we really want to focus on is this diaphragmatic breathing, using your diaphragm to take in deep breaths to help clear your lungs and increase that oxygen intake. We also use breath stacking, which is a technique that we work on in physical therapy on stacking your breaths to increase that inhalation. We're doing that with ambu bags. Some of you, I know that many of the people I work with here and partner with from the ALS Center at Northwestern, we use this technique a lot. It's becoming more and more common to use an ambu bag with that. And most of the research surrounding this respiratory training is in the early stages of ALS. This is probably the least understood area right now for ALS, so I definitely will say that this is something you would not want to attempt on your own. You really want to consult your pulmonologist, consult your physical therapist. A speech language pathologist can give some advice on this as well. They do some work in this for sure. So definitely not something you want to tackle on your own. So now that we understand a little bit better what the recommendations are, we want to talk a little bit about precautions and contraindications. You've heard me mention several times, moderate intensity, avoiding fatigue. So what does that look like a little bit more? Avoiding fatigue, avoiding delayed onset muscle soreness. Delayed onset muscle soreness, if you've ever, gotten back to the gym after a couple weeks or months or years off, you have probably felt this delayed onset muscle soreness. I definitely know I have when I've decided to get back in the gym after a season off. It's that next day, 2-day, 3-day out where my muscles are still so sore. It's sometimes hard for me to walk, hard for me to go downstairs, things like that. This is an example of that delayed onset muscle soreness. Delayed onset muscle soreness is brought on by taking our muscles to exhaustion. So if you're finding that you're getting soreness in muscles that's lasting 24 hours, 48 hours, that means you have hit that muscle exhaustion point and gone way past where we need to go. And that's where we need to focus on scaling back the exercise, scaling back the weight, scaling back the time that you're doing it, and focus on more appropriate parameters. More appropriate after you exercise should be a 30 to 60 minute recovery window. What that means is that after you do an exercise, you should be able to rest for about 30 minutes to 60 minutes. Sometimes it might take that 90-minute window, and then you should feel like I could do that exercise again if I need to. That's really where we're recommending. Doesn't mean that you're gonna do the exercise again, but that you could. All right, we want to avoid significant shortness of breath. Sometimes that's confusing because in that moderate intensity, we are recommending you do get a little bit of breathless, kind of, it's hard to talk sometimes, but that doesn't mean that I'm short of breath to the extent where I couldn't talk to you if I needed to. So moderate intensity, 3 to 4 on the Berg scale. We want to consider balance and safety. We get a lot of weakness through the legs and ankles sometimes with ALS. We want to think about safety to prevent falls. Can our muscles support us when we're standing? I want to make sure we're protecting joints and not putting them at risk for further injury by standing and exercising. So do we need to consider standing versus seated exercises? And then we also want to consider nutrition when we're exercising. If you're noticing I've been starting an exercise program and I'm losing weight, I'm having trouble getting calories in, this is something you definitely want to consult your healthcare team about. That with increased activity, we want to make sure we're supplementing that with the recommended nutrition as well. So a lot of people ask me, they referred to me and said, well, do I need physical therapy with ALS? I've seen research that says it's controversial. I've seen research that I can do it safely. What do I need to do? Well, I'm biased, but my answer is always yes. I think you definitely should partner with a rehab professional. This can look a lot different to a lot of different people. So I want to talk a little bit about how do we partner with someone to establish an exercise program. It might look like seeing a physical therapist for just the initial evaluation and assessment. It might be a one-time visit, a 2 or 3 time visit. It might be that you already have some things in motion where we need to do a little bit more in-depth assessment and treatment approach. So it might be that you see someone for a more standardized program, like a 6 to 8 week program, and then start to taper out. I here at Shirley Ryan Ability Lab often will see people for 1 to 5 visits to just assess, figure out where your baseline function is, talk through any needs or goals of yours, and then to really educate and help you establish an exercise program. That's mainly my job with someone with ALS. And then what I usually do is have someone follow up with me within 4 to 6 months, or if you're noticing any changes that warrant changes to your exercise program. It's really important that once we establish an exercise program that you continue to check in every couple months to make sure that program is still appropriate. And those moderate intensity parameters we've talked about are still appropriate for you. Some people are more comfortable in modifying that program themselves, but if you're not appropriate, it's definitely something that would be a great idea to check in with your rehab team on it. I do want to plug the Academy of Neurologic Physical Therapy, and then Choose PT from the American Physical Therapy Association. These are 2 websites where you are able to go online. You can go to either of these and find a neurologic physical therapist. They don't necessarily specify that they work with ALS, but any kind of neurologic physical therapist should be able to help counsel you through this and educate you and do an initial evaluation, help you establish that exercise program. Excuse me. I know that this has probably been covered in other learning series, and many of you have probably used this tool already, but I just wanted to mention the ALS Association. I did a quick search last night just to see. They do have a nationwide ALS clinic search tool. So I know that there's people from all over on this talk thinking through any one of these comprehensive clinics should be able to help direct you to physical therapists or rehab teams, speech language pathologists, occupational therapists, who are experienced with ALS and have experience putting these exercise programs together. If you're in the Chicago area, we here at Shirley Ryan Ability Lab have a great program. I'd love to partner with you and see you in the clinic. We partner often, like I mentioned, with the Les Turner ALS Center at Northwestern. We offer PT, OT, and speech here as well. And then considering for a lot of people that maybe don't live in an area where there is easy access to an ALS clinic or to a comprehensive care clinic, something like that, there's a lot of telehealth options now. Lots of clinics are doing telehealth. So I would always advise you to reach out and ask, hey, is this an option? Because I think there's more and more of these programs popping up. So I just want to kind of summarize what we talked through today as far as exercise goes. We're really focused on a combination of aerobic training, resistance training, and stretching. This is widely recommended, widely considered safe, focusing on moderate intensity, 3 to 4 on the Borg scale. And then focusing on strong muscles. Again, going back to those muscles that can move through the full range of motion. We want to avoid fatigue and overworking, including any of that continued consistent muscle soreness. Some of my patients ask, well, I exercised and I was very sore. We're all going to have one-off days. One day of soreness would be okay, but we don't want to be exercising at a level where we're consistently getting sore, all right? Identify activities that you enjoy. It's not a one-size-fits-all program. Just because someone goes to the gym, it might mean, hey, you go on a walk, all right? Or someone rides a bike, you might enjoy doing an aerobics class. Again, the way we exercise is way more important than what we do. And then just consider your safety concerns. We want to take balance and safety and fall prevention into it. We want to take respiratory function into consideration. This is where I really recommend you partnering with your rehab team. They can help figure out what are the appropriate parameters for you and how do we change those for future needs. And that is it. I'll leave room for questions. And let me take off my screen. Let's see.
Awesome. Hannah, thank you so much. And you're right, we did have some questions through our pre-registration registration form. And throughout the chat, I'm going through those now. Somebody had a question about taking magnesium to help with muscle cramping. Dr. Jinzi Tanvi from University of Colorado did a fantastic webinar for us last July talking about alternative therapies and treatment for people with ALS, and I believe she covers magnesium there. So please, if you go to our website, lesturnerals.org, you can find that presentation. It's really great. She also talks kind of building off of what Hannah was talking about, but some research she's done with seated yoga and the respiratory benefits surrounding that. So definitely give that a look. And anything else regarding like any specific like supplements or things like that, ALS Untangled is a great website to help you navigate kind of what has the best evidence base surrounding it. Okay, as we're going through another one. Okay, so Hannah, I have a question that came in about eSTEM or NMES, Vital STEM. It goes under a lot of different names. Any recommendations, or can you talk about maybe why this wouldn't necessarily be super appropriate with the ALS population?
Yeah, as far as, is the question, is it specific to vital stem or just the
Vital
NMES?
STEM and electrostimulation.
Okay, you might know more about vital stem,
Yeah.
Anne Marie. I can speak from the electrical stimulation for at least the rest of the body. There is not that much out there concerning this. It's a gray area. We don't know this. I will say that in a therapeutic sense, eSTEM with athletes, things like that, is often used to hypertrophy the muscles or to bulk muscles up. Again, that's something we want to stray away from with ALS. So I can't say definitively if yes or no, but I do know that its intended use normally, we would not recommend it as with exercise in this, because we don't, hypertrophy actually leads to breaking down motor units and then allowing them to heal. With ALS, motor units are already being broken down, so we don't want to do anything that would cause excess motor unit breakage.
Yeah. Couldn't have said it better myself if the person is asking this around swallowing exercises as well. Okay, so you talked a little bit about some exercises that can be done seated. If somebody is safe to go in a pool, would a lot of those same exercises still be appropriate, kind of working off of the resistance in the water?
Very much so. So I have a lot of clients that work out in pools. One thing I think that isn't always thought of that is great is walking in a pool. Walking in a pool provides resistance, working against the water. The faster you walk in water, the harder the resistance is. It also, walking in water, decreases the fall risk. If you fall, you're in the water. So we're okay with that. So I really like the pool. I think a pool is underutilized. I do want to be careful about thinking about respiratory function, getting it cleared with a pulmonologist before you get in a pool. We do have that hydrostatic pressure that pushes on your lungs as you get into a pool. So I definitely would be something that you want to get cleared before you do it. But if you were to come in and say, hey, I love the water. Is this something, can you help me figure out what I could do in the water? We can do aerobic, we can do strengthening. There's all sorts of things we can do in the pool.
Oh, awesome. Yeah, I think that's so important again. And I love how you're continuing to highlight the idea that it's not necessarily, is this exercise good or bad for me? It's more so around the idea of like, what do you find joy in? What do you enjoy doing? And then working with a physical therapist or your ALS care team to then figure out how can you do that safely and how can you continue to maintain that? Or it may look or feel a little bit different, but how could we modify those tasks to kind of continue throughout your ALS diagnosis and journey.
Yeah.
There is a question here about, is it still safe to do active range of motion in the available range with gravity eliminated to maintain? I think there was some question about, you mentioned strengthening muscles that are greater than 3 out of 5 strength can be detrimental. So is it safe to do active range of motion?
I think so. Yeah. I often with partial range of motion, we'll focus on passive range. So having someone help you move that range of motion or to stretch the muscles and maintain the joint mobility. Moving to a partial range, as long as we're not doing it to excess, I think it's a good mobility choice just to keep joints mobile. I would really recommend not doing a ton of reps, no weight, obviously, and fewer reps. So you again don't want to exhaust that muscle, but I think it's pretty safe as far as a strengthening activity. Yeah.
And this next question is taking me back to you and I and the collaboration with PT and SLP at Shirley Ryan. But this person has a question. Her husband has ALS and FTD. So physically, it seems like he can move around, get himself out of the bed, but is seemed to forgetting how to do certain things sometimes, like especially like if he's using a cane. So any suggestions on that? She also goes on to say that trouble repositioning him in the bed since he moves all around in the bed and ends up with his legs dangling. Think that could maybe think about like position of the bed and where it is in the room comes to mind. But yeah, any thoughts, Hannah?
You might be better at this than me.
Yeah. Yeah, so oftentimes Hannah and I or other physical therapists and speech pathologists in the outpatient clinic, there's something called speech retrieval training, where you kind of train something over and over and over again in small incremental time periods. I would say with somebody who has trouble remembering the steps of using a cane or kind of remembering certain exercises, having visuals, having somebody to kind of walk them through that. So oftentimes a speech therapist might be referencing the visuals or creating those visuals while the physical therapist is actually kind of instructing how to certainly implement those strategies. So I think reaching out to a physical therapist and a speech language pathologist, again, that have a neuro background is going to be really, really helpful in creating a care plan where maybe the goal is just working on becoming maybe more independent with using a cane, or if there's a specific gait pattern that we're working towards, or any sort of exercises at home. So if a physical therapist prescribes a home exercise program, and maybe remembering or implementing that plan is really hard for somebody who might have some memory problems, having the speech language pathologist kind of set up a schedule, set them up for success of how they can do that as independently as possible. This person is saying that their back hurts often and they have some truncal weakness. Should they try strengthening that area? Would that help?
It's hard to say without a more of assessment.
Yeah.
We have many things that can lead to pain. So if that's something that's ongoing issue, I would recommend meeting with your doctor, meeting with physical therapist for at least that initial assessment. We're able to do an in-depth pain assessment. With ALS, we talk a lot about neurological impairments and things like that, but it doesn't rule out orthopedic, things like that. Everyone gets back pain, everyone, gets hip pain, or arm, something like that. So just because someone has a diagnosis of ALS doesn't mean that there might just be poor posturing or weakness like you mentioned in the trunk, and that we can't identify some orthopedic needs as well.
Yeah. Um, do we need to buy any fancy equipment? So things like ankle weights or wrist weights or the TheraBand or like resistance bands that you had talked about. Like, um, is that super necessary? Can we do some of these exercises without any equipment?
Yeah, definitely. Modifications can be made. I have the
Yeah.
full spectrum. I have some clients that work out in fancy $1 million gyms, and I have people who are lifting cans of food at home. So all over the spectrum, I would say it can be as in-depth as you want it to be, and that you're within those appropriate parameters. You can use equipment like weight machines and bands and dumbbells. You know, I'm picking up this water bottle right now that probably weighs a pound. So there's no need in buying a 1 pound weight if I'm lifting my 1 pound water bottle. So it's up to you. It's based on your preference. Yeah.
Awesome. Another question came in. I think essentially, is it ever too late to improve muscles, or is it ever too late to start a program?
It's definitely not too late to start a program. Never too late. I will say, as far as improving muscles, once we're past that 3 out of 5 mark or being able to move through the full range of motion, our research does show that there's very little impact that we're going to gain strength in those muscles. And that's why I do focus on those 3 out of 5 muscle strength, those larger groups. But still, I do think, in those weaker muscles, we still want to think through range of motion. We want to make sure we're stretching and maintaining what mobility there is, which can lead to a whole nother sequence of impairments if we're not maintaining range of motion.
Yeah. Somebody else had a question about acupuncture. Again, check out Dr. Tanvi's presentation with us. I believe it was July 2022, alternative therapies and treatment for ALS. I believe she talks about acupuncture in that. And again, anybody with like supplements, definitely check out ALS Untangled. Okay, we answered that one. Hannah, a question did come in our registration, I think from a provider, but their question was, how do you, I think as a physical therapist, present some tips on energy conservation and avoiding overworking without having that message of like, you should stop doing like all exercise or movement?
Yeah, great question. I focus a lot on pacing and energy conservation. How can we make life more efficient? If I not even taking exercise out of the picture and just thinking through my day-to-day routine, kind of what's my space? What in space am I living in that day? What things do I need to accomplish? How can I set the room up, set the house up to make things more efficient? If you're still moving and mobile, you're driving, things like that, how can I structure my day to make it more efficient? Or how can I structure my day to allow some rest breaks? I know that rest breaks for a lot of people who are still early on in the disease journey is, hey, this isn't something I normally do. I don't usually have to take rest breaks. We want to get out of that mindset of I just have to get throughout my day, that we want to think about pacing. How can I integrate knowing that my body needs some rest? So I talk a lot about that, and that could be from someone early on who's still driving, moving about. It could be someone who's using more of a wheelchair user and saying, hey, if you're going to do these 5 things today, can we bring them close to you? Can we structure it where maybe you're doing something that requires the most amount of energy early in the day and then taking rest breaks, and then things that take less energy later in the day, knowing that you maybe get fatigued later in the day. So again, it's an individualized approach, but that's what I usually educate on.
Yeah. Oh, that's great. That's awesome advice. And I think we really hit on a lot of the other questions. Thank you for talking about different stretches for caregivers, especially if somebody has trouble kind of doing the exercise on their own. Is there a way that caregivers could get involved to kind of help keep the integrity of your joints, like through stretching and things like that? Um, and you had references on all of the most recent studies conducted on your slides regarding exercise. So, Hannah, I think we're just at about time. I want to be really conscious of your time. Everyone, Hannah took her lunch period
No worries.
at work today to talk with us. So I really, really appreciate that and want to thank you for that. Before we go, I just want to let you all know if there's any other questions that you may have, I will go through them and we'll make sure that we get you an answer to your question. Um, we have an upcoming webinar for May. This will be on evidence-based consensus guidelines for genetic counseling and testing in ALS with Jennifer Rogenbach, who is a genetic counselor and associate professor at The Ohio State University Wexner Medical Center. Time change though, I want you guys to be mindful of this. This will be at, let me go back, 3 p.m. Central Standard Time, not our usual noon time. So just an FYI about that. And again, if you can't make that time, it will be recorded and on our website. So feel free to still register, but I'll also be sending that link out if you need it. So thank you all so much for all of your questions today. Thank you again. I know this was highly anticipated and we had to postpone it. So thank you so much for being so patient with us. We really appreciate it. As you log off, you will be getting a survey from us. So please feel free to fill that out. Your feedback makes us better providers. It helps us provide better content. So we really take that to heart. Feel free to contact us or follow us on social media. We're on Facebook, Twitter, Instagram, LinkedIn, and YouTube. We have somebody running those accounts who is dying to interact with you all. So please feel free to hit us up. And I want everybody to have a safe and great rest of the day. We look forward to seeing you in May. Have a good one, everybody. Bye.